I didn't.
Well, we can put it up in the
sweatpants.
Yeah.
That's better.
The court shots.
To bring it
I
in a
still
little
think it would
closer.
have been more fun to do this in the exam room.
You are live. Oh, okay.
We could have had.
We're live.
We're live.
We're live. So I would really like to apologize and thank you for your patience. We had some technical difficulties in the beginning, but I want to thank everyone for logging in to the Endo Challenge Live video Q&A with Dr. Andrew Cook, who's the founder and medical director of the Vital Health Institute. He's going to be answering some questions surrounding the myths around endometriosis. You can submit comments and questions while we are live, and we will do our best to get through them. I do need to give a disclaimer that Dr. Cook cannot give any specific medical advice to any individual, so we thank you for understanding that. But before I introduce Dr. Cook, I would like to challenge all of you, if you haven't already done so, to take the Endo Challenge. The Endo Challenge is a social media movement that challenges people to change their profile pictures yellow. And the yellow pictures are a catalyst to start the conversation about endometriosis, which is one of the least understood and underdiagnosed gynecological diseases out there. Part of that is because as women, we're programmed not to talk about or taught not to talk about our periods, infertility, or even our reproductive organs. So this silence is exactly why it takes approximately 10 years for a woman to get diagnosed with endometriosis. So it's time to break this silence, and one of the ways is by participating in the Endo Challenge. I know that we have the power to make a difference by us grouping together and spreading awareness, and it's also my sincere hope that in future, generations won't have to suffer like we have. So now on to Dr. Cook. I'd like to introduce him officially. We're very lucky, actually, he's here. He barely made it, came from surgery. He is a world-renowned excision, or internationally renowned excision specialist and pelvic pain doctor. He works with, like I said, at the Vital Health Institute, which is in Los Gatos, California. You can find out more about him and the Institute at www.vitalhealth.com. And along with Dr. Cook, I have Libby Hopton. She is the Director of Research and Evidence-Based Medicine at the Vital Health Institute, and you may also know her from her work at Endometropolis, which is an open Facebook group to educate women about endometriosis. So let's start with some of the questions that we received, and let's bust these myths surrounding endo. So the first one, Dr. Cook, is why do people, how common is endo? People think it's not common.
Yeah, well, it's very common. I mean, you can figure roughly plus minus 10% of 5.5 million women in North America, 176 million worldwide. So it's actually very common. I think part of the issue is people like yourself, you know, that you look normal on the outside, and I mean, I guess, is it okay to say? I mean,
2 out of 3 women.
2 out of 3, well, people sitting right here have had endometriosis, and you know, they look normal. You wouldn't know who had it by, although I guess men rarely get it. But all kidding aside, you know, women are tough. They put their head down. They live as normal life as possible in spite of all the challenges and pain. And so I think it's hidden in essence. You know, if it was this big fungating lesion or mass, then you know, people would be more aware of it. But there's a lot of women walking around day to day suffering tremendously, but people don't know it by looking at the woman.
That's why they call it the invisible disease, right?
Yeah.
So thank you for that answer. The next question people were wondering about is endo connected to any other diseases like adeno or interstitial cystitis?
Interstitial cystitis?
Yeah,
fibromyalgia?
Fibromyalgia?
It's a really good question, and I'll try not to spend too much time on it, but it's near and dear to where, I mean, I'm a medical doctor, you know, a surgeon. I went into this area of medicine because I like to fix things, and with endometriosis, in spite of what unfortunately the type of surgery that often happens out there, you can remove endometriosis. It can be removed. And so to remove the implants is hugely helpful in the vast majority of people. But the problem with pelvic pain is endometriosis can cause pelvic pain, but not all pelvic pain is endometriosis. And in Western medicine, we really have a geographical and symptom-based paradigm or approach to medicine. In other words, this symptom in this location. And then we try to have surgery or a pharmaceutical to fix it. And what we're learning with more of the holistic approaches with genetics and epigenetics, that there's some common underlying problems in chronic inflammation and things that really are at the core of the disease. And I think what we see is over time, depending on the person's genetics, epigenetics meaning the interaction of the genes and the environment, and then what their exposure will determine what kind of diseases they get. So directly, not necessarily interstitial cystitis, they're called the evil twins, endometriosis and the interstitial cystitis, they're seen about 40% of the time together. Fibromyalgia, there's a lot of overlap. Adenomyosis is kind of endometriosis in the wall of the uterus. But that's why, people talk about excision or versus burning it, and it's very important to do the surgery correctly. But to me, that's just half of the discussion we should be having. The other discussion is health and this chronic inflammation and what we're looking at as far as surgery removes disease, but it doesn't create health. And so it's this other part of holistic and epigenetics and all the science that we're beginning to understand. And that's why at Vital Health we have this comprehensive approach, because that's where we're going to take care of all these kind of issues. So we can talk more about it later, but so the answer is traditionally not directly, but it is an autoimmune disease, and there definitely is a lot of overlap with these other conditions.
So these other conditions are autoimmune, and endo is considered autoimmune, or?
Well, autoimmune's, I guess, not an official member.
Well, I guess
of
the question is,
yeah.
what do we mean by an autoimmune disease?
Right.
Because I think one thing is, if you take arthritis, this is an autoimmune disease where the body's basically attacking itself. Whereas
Right.
one thing of endometriosis can be that it's not an autoimmune disease, but that the disease itself affects the immune system and sort of creates a change. So the question is what...
The chicken or rabbit, because the other thing that they're finding, again, and this is all scientifically based, it's just cutting edge, is that this chronic inflammation that occurs in the body, and we're not going to get into all the causes, but this is chronic inflammation. It's becoming very evident that endometriosis, heart disease, diabetes, all these things is chronic inflammation is underlying. And we see quite a few patients where they have low-grade ANA that's positive, and then is that an autoimmune disease? They go to a rheumatologist and they get a workup, and they say, well, you don't really fit a classification, but we'll keep an eye on it. So the concept of autoimmune disease, I think, is being redefined as we're sitting here. And so, again, it's a little shift in paradigm, but this chronic inflammation is not normal, but it's very prevalent in the United States. The majority of people have a problem with this, and it relates in part to our diet, and there's going to be questions about diet too. And it's a huge problem, but so.
That actually segues into our next question, which is, we hear a lot about the endo diet, and so does having a special diet make endo go away, or do you believe it can lessen the symptoms? Like, you kind of answered that, I think, in that last question, but maybe give us your opinion.
To touch on a few aspects of it. So the short answer, no, it doesn't make it go away. Now, I've seen patients come in that think they have endo, and it turns out that they have a gluten sensitivity or whatnot. We get them off the gluten, and their pain goes away. So they probably didn't have endo. It was misinterpreted and misdiagnosed as that. So it doesn't make it go away, but yes, diet plays a huge role in it. The majority of people, if you look at all the processed foods and inflammatory diet, that there's a book called The Blood Sugar Solution by Mark Hyman. It has a lot of good points in it. And so there's sensitivities, there's allergies. We get into the whole GI tract, the dysbiosis, if that ecosystem's out, it starts causing more food allergies or sensitivities. And so it's probably beyond the scope of what we're talking about today, but these are all things in my mind, even as an excisional surgeon, that these are important things that we need to look at to really get people healthy. Okay.
So the next question we got, and I know this can be kind of a controversial one that I've learned from some of the Facebook groups, is Lupron a cure or a recommended treatment for endometriosis?
Well, I guess my bias is I rarely, almost never use Lupron. Now, yes, it's a treatment option. In anything in medicine, we need to understand what are the potential pros and cons. And the problem I have with Lupron is it's very crude treatment. It has significant side effects, and usually there's better treatment modalities, more successful, less side effects, but it is an option out there. But no, it doesn't cure endo. And the problem is it only turns off the estrogen production by the ovaries. So the endometriosis can produce its own estrogen. So the whole concept that if you've had a hysterectomy or you're on Lupron or you're postmenopausal that you can't have endo is wrong.
Would you say, just a question to add to this question, would you say that there may be patients who've had their endo removed, but they might still have pain because they want to retain their uterus, and they maybe have adenomyosis? Is that more a scenario where drugs like Lupron, if everything else fails, would that be sort of the exceptional situation where a patient, I don't know, just sort of understand where it fits within the whole grand scheme of things?
Yeah, that's the kind of situation where there's no easy answer. Adenomyosis, yes, hysterectomy is an answer, but it's where you really need to sit down and talk about what is the situation, what are my options. And Lupron would be one of those, to go through. And
for women that are preserving their fertility?
Preserving fertility, we also look at, xenoestrogens, how much estrogen you get in the environment, how you metabolize an estrogen, cruciferous vegetables. So there's a lot of things to look at to try to optimize health. Usually try to start with the least side effects, the least invasive, and if we can make enough improvement in lifestyle skill, then great. If we can't, then we look at more aggressive treatments.
Okay. It seems that too many doctors are jumping on Lupron before other things have been tried, and not necessarily telling the patient that there are other options. So they feel, this is my only option.
Well, I hear all the time, well, I'm sorry, we did surgery, it didn't work, so you can either do Lupron or you can do hysterectomy. You say, wait a minute, you're 25, you haven't had kids, and what about taking all the endo out?
Which is actually one of the biggest myths out there. And one of the next questions we have is, people believe hysterectomy is a cure. You hear it all the time. So why or why not is hysterectomy? Why do people believe that? Where did that?
I don't know. It's probably a bigger operation that gynecologists can do, and if one's very cynical, then if you get rid of the uterus, you don't have to deal with the problem anymore because it's no longer a G1N problem. But I've had the argument too, where talking with people, well, hysterectomy doesn't cure into endometriosis. It is often next to the uterus, behind the uterus, over the bowel, but it's not on the uterus itself. So to take the uterus out and leave the endometriosis is a disservice. And then I hear the argument, well, take the ovaries out too. Endometriosis can produce its own estrogen, so taking the ovaries out, especially in a young woman, you're taking androgen production, sex drive, bone density, osteoporosis, all those potential complications. It's just not an appropriate treatment. Now, if you're taking endometriosis out, the woman's finished having periods, if we're worried about adenomyosis, then maintain the ovaries, but there's a consideration if we seem to have the uterus itself as part of the pain generator, then we can consider doing hysterectomy in addition to with the primary thing of removing endometriosis.
Because I think the short answer is you can remove all your female organs. If you leave the endo behind, you're still going to have endometriosis. So hysterectomy is not a cure.
Well, the only thing that has to be said, because people tend to think in black and white, and they say, okay, removing the ovaries isn't going to help you. The research actually says that something like 85% of patients with endometriosis who have their ovaries removed, which it will have relief. So it's actually, many doctors say this is actually very effective, but there's a big price to pay potentially, because you're put in surgical menopause. You can end up, maybe if you're lucky, fixing one problem, and then you end up potentially having a whole host of other problems. Your life expectancy may be shortened by 10, 15 years.
But then you got to look at the study and what are they doing, because if you just don't take the endometriosis out, you got over 85%. You're talking about quality of life and osteoporosis related illness is a bigger,
Now they put
is
on
the
replacement
biggest
therapy.
healthcare problem with women right now. And so we're trading one disease for another. So
Yeah.
I'm very adamant about trying to maintain ovaries. You know, I think if
You
it
can
was a
be-
male disease and we're trying to remove the testicles, it wouldn't be doing, it would
Would
not
be
be
an
a common
international
procedure.
emergency.
Well, it may be an
Endometriosis
international
would.
solution to a lot of our
Yeah,
problems.
maybe.
Anyway,
All right,
we
that's it.
digress.
You
Yeah, we
volunteering?
digress. This I've been hearing a lot about lately. I'm not sure if there's been new research on it, but we had a question about women
Oh.
believing that microscopic endo and it can't be seen or removed, and that's why they continue to have pain. What's your thoughts on that?
Well, I'll give you my 2 cents, and I know Libby has some opinions. So there's a couple things. One, I did my fellowship at Johns Hopkins. A couple of years ahead of me was Anna Murphy. She did research with the scanning electron microscopy and looked at normal peritoneum in between the endometriosis implants and saw or found endometriosis quite often there. When back in the day, I mean, we've done laparoscopy, but also have had operative microscopes in the past, which give additional magnification. And I know from doing both of those procedures in the same patient that even with maximum magnification on the laparoscope, you still cannot get good enough resolution to see everything. And then I did a series where we did the wide excision, but before we outlined it, but then we took as a specimen all the visible endometriosis, and then the Swiss cheese that was left behind we did as B. And 2/3 of the time we found and the pathology, so looking under the microscope, endometriosis where you couldn't see it with the laparoscope.
So what's the solution?
Well, I think that we know, so the solution is you have to know what all the myriad of different kinds of ways that endometriosis looks. And then we know that wherever you can see it, that within about an inch beyond, that there can be smaller lesions. So it clusters. And you look at the cluster, you look at where it is, and then you have to do, and that's why the wide excision. It's like if I had
Because not everyone does that.
No.
When you see the surgery videos, some people they have the lesions just really narrow margins,
right.
and then others it's almost like total peritoneal
right. So
excision
even excision,
in some cases.
Right, and there's probably I would lean towards that approach myself. And the easiest way for people to think about it, if you had a mole on your hand, and if the doctor was concerned it might be a melanoma, you know they wouldn't just burn it, which is what most endometriosis surgery is. And even if you excised it and just cut right around it, most people know, I mean, that's going to have a higher recurrence rate because there's actually microscopic cells. So you take a little bit of normal looking skin, just because, statistically there's going to be some cells that spread out. And that's why with wide excision, like in our data, we see 7.7% recurrence because it's you from the pattern and where you're looking and you get that little border of normal tissue, that's your best bet for really getting out of the disease.
Okay.
So related
to that.
Can I
Next question.
add to
Oh.
very
Yeah,
quickly?
quickly. Go ahead.
Okay. You mentioned Murphy.
Yeah.
The only thing I'd say about Murphy's data, she found was it he? She was
Anna.
I bet it's Anna, but I was worried about.
Yeah.
So she found, I think, in 30% of samples, presence of disease in normal-looking tissue. But her approach was via laparoscopy, open surgery. So she
Right.
was looking at the disease from some distance. So bearing in mind that.
But they used loops back then too.
Okay.
So they did have magnification.
But bearing in mind that there was less magnification than now, and yet still only 30% of samples. It shows that even in the worst situation, worst conditions, and she didn't use strict criteria of what's normal, what's not normal, which would be beneficial. The majority of patients would not have microscopic disease, or what I wanted to stress is that most patients who have their disease removed do not later have more disease present.
Right.
So if the question is, is it about visualization? Is it about it not being visible? Is it about the fact that just surgeons are humans and that it's not easy to...
Well, I think, quite frankly, the way that endometriosis looks at so many different things. Even, I'm getting older than that old, but even it was up until the 70s when Jensen out of Australia rediscovered that there was atypical non-pigmented endometriosis, what Sampson had described in the 20s. So I think the biggest factor, quite frankly, is probably the skill and experience of the surgeon looking at it and realizing. And my take-home message would be to anybody is, if it's not normal, then it's probably endo. We need to remove it.
Okay, so let's move on to the next one. There's some questions about, do teens get endo? And then the follow-up question to that you probably can answer in one is, can someone be too young for excision surgery or surgery to confirm or treat endometriosis?
We got your questions.
You got a smart, educated audience.
They've reported it before periods, so it can be very young. I've seen it, I think, 11, 12, 13 myself. And so, no, it can happen very early on. Is it too young to do surgery? I think, I see that quite a bit where, you have a teenager and they come in and they're hurting a lot, they're non-functional because of the pain, and you have the surgeon saying, well, we don't want to operate because we don't want to give you scar tissue. Well, one, again, that's a myth, because if you're gentle with the tissue, and yes, surgery is traumatic, but if you have good surgical technique, the chance of scar tissue is very, very low. And the flip side, my argument is, okay, if you have severe excruciating pain and you're 25, then you're qualified for treatment. But if you have that same level of excruciating pain when you're 15,
right,
you have to live with it. I mean, it's absurd.
Yeah.
So no, it needs to be treated. All women, all ages.
I'm wondering if that question might have stemmed from, I think I've read somewhere that teens their endometriosis continues to grow until a certain age or something. Is there any truth behind that? Or is that
you need to address it too, Libby, but I think the important thing to me is, in the teenage years, you got to come back to what we call the terrain. What's, their body, their environment, what's going on from a health standpoint. And that's where we really have to look. And again, it's beyond it. There's this whole developing field of the microbiome. There's actually 10 trillion bacteria, and they've got 10 times the number of cells that we have as human cells. And that whole genome is very influential in our health. There's just a report out this week about how that probably affects autism spectrum disorder. And it's been shown with weight, you can do a fecal transplant, and people that are heavy can become thinner. So the microbiome's a very hot area of
Sounds quite disgusting.
Wow. But we'll move on. We won't talk about that.
So
but the take-home message is, that, again, you have to look at the person overall. And yes, there's been a lot of work. Thanks for David Redwine, for getting the idea that you have to get around and size these implants and do it. But part of my mission is, yes, we do need to do that, and we also need to look at the overall health of the person and combine all this, because it's surgery is so important to get it out, to get it treated correctly, but it doesn't stop there.
Yeah, that's something. There's one idea that, and that's quite a popular idea, that in teenagers the disease can be more aggressive, it may be more likely to recur. That doesn't mean it necessarily will, and that shouldn't justify not doing surgery, because, if anything, teens are, those are like the most critical years. If they're in pain during their formative years, they're going to miss out on so much. And teenage years set you up for the rest of your life. So if you can help a teenager and
do we really know too? You have people not even wanting to operate, and the people that are operating, one could argue that it's not unreasonable. They would be more conservative and thus less likely to fully treat it. And then you have partial treatment. And you're into this crazy cycle of recurrent surgery.
So if your surgeon doesn't want to operate, really that's a bit of a red flag, because it means that either they don't believe into the surgery because maybe their own clinical outcomes are not particularly good, or that they're going to do a sort of half-hearted effort. So
here's another question, and I've seen that people describe it sometimes, which I know is a myth, that endo cells can migrate, or like cancer, spreading through the pelvic cavity. So
we see it at surgery. We have little slings. And I don't know that
I think the first question is, do you mean endo cells, or do you mean, when you say endo cells?
They probably mean it's endometriosis.
Endometriosis rather than, because endo can, I guess the first question, endometrium and endometriosis are two different things. So with the the lining of the uterus, you have this basement membrane which allows that tissue to shed each month and then rejuvenate. And that's not the case with endometriosis. We know from the histology it doesn't shed and rejuvenate. So
yeah, and probably, and this gets into a little bit to my opinion. I don't know if it's been documented yet, but probably stage 1 and 2 is a different disease than 3 and 4. 3 and 4 is, in essence, grows just like a local cancer that doesn't metastasize. Locally invasive. You know, we get it in the diaphragm, so it spreads, it can wash, it can get lymphatics, it can get bloodstream, it can get in the abdominal wall from C-section. So there's ways that it gets around the more aggressive disease. Certainly, however it does it, floating around tissue, it does seem to spread, quote unquote, more. It probably is more likely to implant or take hold, I think, with the more aggressive types of endo. I don't know either.
I'm not convinced.
Well,
I guess what I'd say is, do you find that those patients who have the very severe cases, when you remove all their disease, do you have the impression that they're the ones more likely to end up having to have more surgery, or is that not really the case?
Not necessarily.
So it seems that removing it can stop whatever's going on.
Right, I think, because again, the idea, if you really get around it, then it's probably gone for the duration. I think in our experience with recurrence, maybe, so a couple % of the time, I can see it where I know we've really gone after it, and just every international specialist when I've operated on their patients, we all have some recurrence, and it's just the nature of the disease. And I'm not even going to go down the road of debating what causes it, and is it metaplasia versus retrograde menstruation, because we really don't know. But we know sometimes it's lymphatic, hematologic, direct. So it's probably different ways.
Okay, I think that answers that question. So the next question, someone wanted to know is, can endo be excised from everywhere, or are there places where it cannot be removed safely? You just talked about the diaphragm. Can it be excised from places like that?
Yeah, for all practical purposes, yes. I mean, I hear all the time that, well, we still had endo because it was on the bowel, it was already good, and it wasn't safe to do it. And, I guess, I want to defend the general OBGYNs out there, and that I think they're being asked to do something that's not reasonable. But it's also one of the more complex diseases, and it should be a specialty. And the surgical skill set that's required is, depending on the case, it can be among the most difficult surgeries out there. There are local GYN oncologists we work with. I think 2 of the top 5 cases, the most difficult cases are my cases. And so it can be very challenging, but with the proper training and experience and tools, for all practical purposes, it can be removed from wherever it needs to be.
I guess this question provides an opportunity to discuss. There are cases, take the ovary, when someone has, it could be surface hemorrhage, or it could be very superficial disease, covering a large area of the outside of the ovary. Excising that would potentially cause a lot more damage than vaporizing, and this is generally, this is standard. I don't think there is no excision surgeon out there who would excise superficial surface hemorrhage from an ovary, because if you did that, you'd basically be causing unnecessary damage.
Removal of eggs and ovary. Yeah, because the reality is,
so that might
excision,
be an exception. You could, but maybe you wouldn't want to. You could compromise
more damage than
excise.
They only had 10 surgeries and did that.
Excision, laparoscopic excision, 99% of the time, is linear vaporization.
Which is excision.
So excision is linear vaporization.
Okay, same.
And that's the core of what happens day in and day out for anybody that knows what they're doing with endometriosis surgery. What you're talking about is very small lesions in areas that are in the fallopian tubes. It's the same thing. So there's some places where you could excise the fallopian tube, but we don't want to, and it's right on blood vessels. And so little areas you can do area vaporization, and it's not burning. It's the same as excising.
And what would be the advantage of doing that instead of excising?
Well, it's more precise, and so it's hugely time consuming. You know, I mean, where you can excise a huge area in a short amount of time. And so the thing with area vaporization, practically it's a smaller area, and you have to be very compulsive to make sure you're not missing any islands of tissue. And we'll try to do a video to show it sometime, but it's the same thing
Because
as
what I can
excising.
imagine, say you have an area of disease on the fallopian tube and you cut it out, you could end up cutting into the, you basically could end up having to open the tube and then you suture it and then scar tissue could form, the tube's blocked, and that's, you know, going to potentially prevent someone from getting pregnant spontaneously. Whereas I guess if you can preserve that without going through the wall of the tube, these kind of things is often, I guess, fertility related.
I mean, certainly if somebody has, which is not that common, but if it's endometriosis invading the fallopian tube and not good for fertility, then it's
not common.
Okay, let me this is a good question, because I know a lot of people out there believe this is to be true. Do women with endo only get pain during their menstrual cycles?
It's most common that it starts that way, but eventually it'll progress to where it's 24/7. So, you know, it's, no. If you have pain all the time, it can be definitely.
It's still endo related. Another one out there we hear women getting told by their OBGYNs is pregnancy will cure endometriosis.
Yep, just go get knocked out and stay in the past. And the next question?
Keep barefoot and pregnant and you'll be done with cured from endo?
So,
no, it's,
only if you have 20 children.
Well, twins and triplets is even better.
Yeah, preferably.
No, all kidding aside, I mean, certainly if, so back to the previous question, if you have painful periods, pregnancy definitely fixes that for about a year.
Right.
9 months, depends how much you breastfeed.
Although some women actually say they have more pain during pregnancy.
Yeah, it is possible. You know, so it's, you have the immunologic changes during pregnancy, and it definitely can help out, but it's not a cure, or moms wouldn't have endo.
Right.
No, and actually a lot of the, some of the early studies, more than 50% of the women in these samples have had children. So it's kind of funny in a way that there's this illusion that, I mean, I see women on endometriosis say, yeah, my doctor says it can't be endo because I've already had kids.
Right.
Well, hello.
The two aren't related, right?
Yeah,
this is a good one too, because maybe you can explain why. So the question is endo pain really that bad? All women get period pain, so what makes endo different, right?
Yeah, I see that, and you know, I hear, so I don't have endo myself, but you know, women that, and it seems like sometimes the female bosses are the worst because they say, well, I have periods, and I push through it and whatnot, right? But you know, I think the thing that's most common is, you know, I'll have patients that they have this pain, they've been living with it, and one example was this gal, she almost went to the Olympics about 20 years ago. They'd been through numerous surgeries, the hysterectomy, took the ovaries out, she's in all this pain. 4 days after surgery, as you know, we're on the 3rd floor here. She came up 4 days after surgery, up the stairs, no pain meds, saying this is a piece of cake compared to what I've been living with every day. And so I see that time and again where the surgery pain is so much less than the endo pain. And so if you went and surveyed the general public and said, do you think it'd be reasonable to go through major surgery without any pain meds? And people say, no, that's ridiculous. But yet they're being expected with endometriosis to live with pain worse than that every month. You know, and every month. So you know, okay, I just got through with that, but now in 3 weeks, it's coming again. You know?
Some women 24/7.
Yeah. Exactly.
So this is a good one too for the endo myths. We often hear, oh, I know someone who had endo and she did blah 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 and it's fine. Now you should do that too. Can you respond to that mentality?
Yeah,
Sure, you get women come into your office all the time with stories about this worked for my friend.
I think people like to offer advice, even if it's not always, you know, helpful.
Yeah.
But yeah, people just want to be helpful, and I don't know how the best way to respond to that is, but probably say, well, thanks, but everyone's different.
Right.
And, you know, I'm glad that worked for you.
Yeah.
Yeah, and also a lot of people, endo, they might refer to their problem as endo, but, you know, say someone had never had surgery and they thought they had endo.
Right.
Like you mentioned about you've had patients who maybe had a gluten reaction, you know, sensitivity or intolerance, I should say. and then they changed their diet and they felt great, but maybe they never had endo. Unless you have surgery and it's actually diagnosed, you don't really know what's going on. So yeah, maybe giving up bananas for a month really fixed someone's problem, but maybe they didn't have endo.
Right. And I think the analogy I use sometimes is if somebody comes in with pain, some patients it'll be 100% endo is causing pain. But other patients there may be 5 different things, and maybe it is some bleed, it is some endo, and maybe IC or pelvic floor spasm. And so the idea if you're sitting on a thumbtack and you take it out, you're going to feel better. If you're sitting on 5 and you take 1 out, then it's not.
Yeah.
And it may be that there are patients that have endo where it's not the majority of the pain generated. There's something else. And so, everybody wants to be helpful, but bottom line, it's complex, and you really need to look at the comprehensive situation of the patient and do a detailed history.
Mm-hmm. So our next question is actually a little bit redundant, but maybe we can talk a little bit more about why it's so important to see an excision specialist. It says, why can't all gynecologists treat endo, and why do women need to see specialists? There's very few of you out there.
Yeah, I think unfortunately there's just a lot of misconceptions about endometriosis, and that's true with the majority of physicians, as well as the general population. And then the endometriosis, again, there's pelvic pain, there's endometriosis, there's, the seems that Lupron can be very much pushed to be the treatment. And I was at a conference with pelvic pain, and the discussion was, well, when are we going to quit doing these ineffective surgeries? And my jaw just about dropped. So when are we going to start doing the right surgery? Because when you do it, then the majority of the time it works. So it's very complex. The reason we have specialists is because there's a specific area that has so much information that it's hard to know all that and to do other things. And so just like heart surgery, or cancer, you want to go to a specialist that really knows all the related stuff.
Right. So in that, is that typically because the gynecologists aren't being in medical school educated specifically on endo, or is it?
Correct.
Yeah. So that's maybe some other part where we need to bring some more awareness, right? So I hear pros and cons on this. It says, will exercise help with endo? And if I lose weight, will that help? There's some theory about fat cells and estrogen. I think that's where that myth may have come from.
Yeah, and I think probably more importantly, so if we look at, in the United States, 2/3 of people are obese, or overweight, I should say. And a lot of that is because of the SAD diet, the standard American diet, not a processed food. So you always have to look at what is specifically going on. So underlying inflammation, health, in general, does exercise help? Yeah, it helps in a lot of ways as far as overall health, this end of lifestyle therapy. Stress, does stress cause it? No, it doesn't cause it, but if you're under a lot of stress, you get into adaptive mode, and then try to get help. That's good for surviving, but not for flourishing. And so it helps to do mindfulness and stress reduction and to try to get sleep. And some of this is nice theory, but if you're hurting myself,
it's hard to get out there and do it, right?
So again, it's not if you just do this, then it'll be better. It's really trying to look at the overall, all the different things that come together to give whatever situation you're in.
So exercise is just part of the whole holistic.
Yeah, so so obviously if you're hurting so much you can't move, then that's not an option. But there are people, if you can get out and just walking or some kind of movement, it's going to help in a lot of different underlying ways. And if people are overweight, but quite frankly, the majority of people, and I was guilty of that myself, eating too much processed foods, and you get it out, and it starts to change.
Okay, so this is one that I've seen someone on the Facebook groups have their doctor say to them. The question is there a correlation between sexual assault, abuse, abortion, and endo?
Go ahead.
So, of course, it's not the case that, you've internalized your pain from, being sexually abused or assaulted when you were younger, and that's why you're now complaining of pain all the time. That's just rubbish. And but there is an association between previous stressful life events, which can include abuse, not necessarily just sexual abuse, but physical abuse, basically being in a highly stressful situation. So it may not just be about abuse, but it could be about all kinds of things that are major stresses, have been found to be associated not just with endometriosis, but with cancer, with cardiovascular disease, and it's likely to be, rather than a direct kind of causal relationship, stress just isn't good for the body, and it affects your cortisol levels, which in turn can affect the way you perceive pain. If you're in more pain, you're more likely to be diagnosed. It can affect inflammation. So that it's a complex relationship. So yeah, the answer is yes and no.
It's a hormonal domino effect too, because the cortisol and the sex hormones and thyroid and everything, they all interrelate.
So I guess the answer is having stress in your past isn't good. I mean, they did animal studies on this also, and they looked at the prevalence of spontaneous naturally occurring endometriosis in these primates that they also get endometriosis. And some were raised in a stressful environment, and some were raised in a non-stressful environment, and the ones in the stressful environment were more likely to have endometriosis. So it seems to have some, stress isn't good. So whether it makes the disease, it can, I don't know.
But what I'm hearing that you could not assault, abuse, or abortion or any of the above cannot cause endometriosis.
No, it's not like
that's the myth you wanted.
It's not the case that a miscarriage. I had a miscarriage and therefore I have endo. No, that's just not. I mean, you can't link it specifically.
Those things cannot cause endo. So
no, it's no direct.
So another, I hear this a lot too, is doctors will refer their patients to see psychiatrists. Kind of treating that it's in their head. What would you say to that?
So it's, to use your term, rubbish. The problem in medicine is one of the problems I see is the physician doesn't know what's going on, and they tend to start to blame the patient. And we don't have all the tests that we want, or we don't have all the treatments that we want. But it's not. So again, people can have stress. They may be in a stress response mode, and that can contribute to their ability to deal with things or not. We know that physiologically that the functional hormones things change, but that is not the cause. And I see it time and time again. Endometriosis is the cause. They've overlooked it. They haven't seen it. They haven't treated it properly. They've taken half of it out, and they're blaming the patient. That the continued pain and the reason to go on to be intimate with your husband is you must have some kind of avoidance here, and the reality is they haven't done the job. So, no, it's not in their head.
Just one thing, when all's said and done, when a patient, assuming a patient has good surgery, has good treatment, the pain is not in their head, but something that often seems to be neglected is the impact of this disease on the way a person feels about themselves, their self-esteem. I mean, being in pain all the time doesn't just have an effect physically on you, but it can have a huge effect on mentally, because you're cut off from all your friends, you might have lost your job, you have a lot of stress maybe financially. I mean, this disease can impact on pretty much every aspect of your life, including your mental life, and there's no shame in seeking help for that too, just as you would, maybe make changes to your diet. And also, I mean, something I've come across with some patients, maybe they've been in pain for 20 years, they've had surgery, and they've actually done really well, they've their life's turned around, yet they suddenly feel almost like survivor guilt, like they almost feel like they're dealing with a trauma. And that needs to be addressed as well.
Which I think is really important. So there's a term that I think is important to put out here, and that is self-care. Because in the United States, especially for women, I think the idea that you got to take care of yourself doesn't necessarily up there with your kids and the husband and all this other stuff. But the other thing that I see, I have had patients come in and their pain's gone, they're feeling great from that standpoint, but they're like, I'm feeling depressed. Now what's wrong with me? There must be really something wrong. And I think sometimes what's going on is a little bit what you're alluding to, but some of it is grieving, because sometimes people come in, it's like, wow, that actually wasn't that hard to get treated. And it's been 10 years or 15 years. And then, so there's all this time that's lost, there's all these opportunities lost. And so when you're in survival mode, you're just surviving. When you start to get well and healthy, then you have time to start to reflect on it. So if you're feeling down, or depressed or melancholy. That's some of it, and it is, it's kind of like a person in jail. You think, well, if you just get out, I'll be fine. If I just get out, I'll be fine. But then you get out, and it's like, wait a minute. Like you said, I've lost all my friends. I don't have any activities, and it's really integrating back into a normal life and rebuilding a life. And it is a process.
That's an important point. This one is, does endo always equal infertility?
No.
No. I know that we know lots of moms that suffer with endo, that excision, either prior or after. This is a good question, though, I think. Does endo only appear in the pelvic area?
No.
I think you addressed that already.
Yeah, and it's most common in the pelvis, but it can cases been reported in every organ of the body.
Oh, every organ.
They always say every organ except the spleen, and I think, well, how did they come up with that? Did they examine the spleen of every?
Everybody stays away from the spleen.
It's kind of it's a little bit random to me.
Yeah.
Okay.
But it can go
anyway,
for
it can
brain
go.
and
It's
like that.
Well, going back to your first question, how endometriosis isn't common, is it? The first question.
Right.
Endometriosis is very common, but it's extremely it's extremely rare to find endometriosis in the brain. I mean, maybe there have been a handful of cases ever documented. So it's important that people who have endometriosis don't freak out and think, oh, it's going to spread to my brain,
right.
my lungs, and I'm going to die, or it's not a deadly illness, and it's very, very, very rare. It's if you find, sometimes I see people say, oh, I have something was seen on my liver. I think it's endometriosis. Well, statistically, the chances are you have something else. It's not it's not common to have it in these. I mean, I don't know how many brain tumors have you removed?
I haven't, and it.
Goodness, right?
Yeah.
So let me ask. This is also very misunderstood when it comes to staging. I think there's some myths that go along with this. So the question is, does minimal disease cause minimal symptoms?
No, not necessarily. I've had patients that have been told they've had a laparoscopy. They've been told that they don't have endometriosis and they have severe disabling pain and high-dose narcotics. And they go look, and it's minimal. It's what they call miliary, so it's clear, vesicular, the little clear bubbles almost, which are easy just to look through. But the same thing, you have to get up close and look and whatnot. So it doesn't necessarily correlate. You could speak to it a little bit more, but the bottom line is, just because it's not huge, bad looking stuff, it doesn't mean that it can't be horrible disease. And I've had patients say that it doesn't look that bad. It's kind of really caused that much pain. And my analogy is, well, show me how big a hormone is, and we all know how much that can affect. So it doesn't. It's not size dependent.
So the next question is, can endo be diagnosed by anything besides surgery? There's so many doctors sending women for ultrasounds and MRI and CT scans.
Yeah, I mean, there's ways that you may be able to pick up endo. I mean, if you have an endometrioma or quite a bit, a large nodule or invasive disease, then it's possible to see it with this. To me, the most accurate test is the history. When you sit down, shut up, listen to the patient, they're going to tell you. And, so these other things can help aid, but there's no non-surgical.
Like if you do an ultrasound and you don't see any nodules or endometriomas, you're not going to say to the patient, oh, then you don't have endo.
No.
So I guess the answer truly is, though, to answer that question specifically, to really truly diagnose endometriosis, you do need to send a sample to a lab, right? It can't be, there's no blood test or
no, there's no non-invasive test. And usually to get the sample of tissue, you have to do surgery. Occasionally, someone can have, there are cases where endometriosis is found in the belly button, and then in theory, you wouldn't need to do a laparoscopy to diagnose that, because you could do a biopsy without doing a laparoscopy.
And I think that's the flip side is you'll see some of the holistic treatments, which I'm all for, but you'll see claims where this formula or this treatment, cured the endo. Well, again, you go back, it's never been documented. And so I think a word of caution of different claims as far as treating endo, just like cancer, basically you got to go get it out.
Okay. We also had a question about natural products treating endo. Can they do harm?
Sure, they can do harm. you know, and it gets back in the same thing. You know, if you start talking about so natural products are great and supportive of it, you know, like the holistic approach, but you get into different supplements and stuff, you can start looking at the methylation pathway and SNPs or single nucleotide polymorphism and trying to add this supplement to help, but it's a domino effect, and you really need to be with somebody who knows what they're doing. So in general,
I mean, the thing is with natural products, there isn't the same, how do you call it, the same control, I guess, over their production. So you need to know, and you also need to be careful.
Right?
For example, like take St. John's wort as just a random example. It can interfere with birth control pill. So I mean, there are things you need to know if if you decide to start dabbling with natural products. It's good to be
quality of the product too. It's less regulated.
That's right. That's kind of what I mean.
So I think there's different modalities and treatments. I think it's always be smart, be informed, whether you're talking about surgery or some herb or essential oil. But
be informed is a good one. So the last question we have, which we kind of have probably already answered, but I'm going to ask you anyway. Someone was told that endometriosis occurs more often in women that have delayed, when they get it later in age, childbirth. They wait until they get older. Is there any correlation, or is that just a myth?
As far as I know, the only reason I can imagine that someone is more likely to, I don't think there's any evidence to say that these women are more likely to have the disease, but given the disease can only be diagnosed by having surgery, and you'd only have surgery usually if you had a reason to have surgery, so you'd have pain. I guess if someone had had children and they'd had, maybe been on the pill, then they had children, and while they, were pregnant and breastfeeding, if they were lucky enough not to have, many symptoms, they might not get diagnosed simply because the problem didn't rear its head until later. Mm-hmm. Whereas if someone had never taken the pill,
right, I mean, there's things like breast cancer is a little higher without delayed childbearing, that kind of thing. So you could argue from an estrogen-dependent standpoint, does it have an effect?
The disease has more opportunity to invade if it were invaded.
I think diagnose it later in age.
But I think what you alluded to at the very beginning is that average 10-year delay in diagnosis. And so it's just important, especially if it's progressive pain, if it's severe, if it's disabling with your period, if the days are getting more painful, if the number of days are getting more than the month that you're hurting, that to me that's endometriosis until proven otherwise. And I don't care what your doctor says, listen to your body.
Can I add just a couple of questions?
Sure.
There's someone had specifically asked me whether you would answer this, because you do a lot of adhesion cases. No. So you do a lot of adhesions.
Yeah.
And the question was, when you go in and you say the patient has adhesions, can you tell whether those adhesions are from the endo or whether they're from previous surgeries? Is it easy to tell?
Often not. You really don't know.
They just look the same.
Again, it's either normal or not. It can be adhesions or scar tissue only. It can be a combination of scar tissue and endo. It can be endo only. We may not know, especially when they've had repetitive surgery, because endo starts to look more just like fibrosis or scar tissue. But they can all cause pain, because adhesions really are a non-specific healing response. So is it damage from endo, previous surgery, infection? We don't necessarily know.
Okay, I think that wraps it up. I want to thank Dr. Cook again and Libby Hopton.
Thanks, Jennifer. I appreciate it.
Yeah, we're happy to have you. Endo Challenge plans on hosting more question and answer sessions. And remember, everybody, please turn your profile pictures yellow during the month of March. Thank you.
All right, take care.
Bye-bye.
Bye.